for giving me this opportunity. In the next 15 minutes or so, I'll talk about breakthroughs in cellular therapy and immunotherapy. I've tried to collect data from the last 4 to 5 years. Initially, I'll talk about breakthroughs in stem cell transplantation, which include newer treatment options for graft versus host disease, treatment options for CME infection, and strategies that are being used to reduce relapses post-transplant, and strategies to improve access to stem cell transplant, followed by a few slides on chimeric antigen T-cell receptor therapy. We know that the efficacy of allogenic transplant is limited by morbidity and mortality caused by graft versus host disease. Graft versus host disease may occur in between 30 to 70% of patients, depending on the type of transplants patients undergo, RIC versus MAC transplant. In patients who do develop chronic GVHD, nearly 50% would require second-line treatment. And we know that development of a resistant GVHD increases non-relapsed mortality by more than 2.5 times. Till recently, there are no US FDA-approved therapies for chronic graft versus host disease. David Milkos and colleagues published in Blood a couple of years ago a data of using IBRUTINIB in patients with resistant chronic graft versus host disease, which is an open-label multi-center study, and demonstrated that addition of ibrutinib in resistant chronic graft versus host disease led to increase in overall responses up to 70%. And they also demonstrated that the responders required less steroids over a period of time, and the requirement of steroids reduced even up to 1 year once the ibrutinib was started. Hence, ibrutinib was shown to lead to sustained responses and was tolerated well and had an excellent steroid-sparing effect. Ibrutinib has become the new standard of care in second line in chronic graft versus host disease. We also know that acute GVHD is a major problem in allotransplant, and depending upon the type of transplant, up to 50% of patients do develop acute graft versus host disease. And half of these patients are steroid refractory. And yet, there is no standard second line for these patients, and most of the drugs that have been tried have not delivered good results. In this trial published in the New England Journal of Medicine recently, which is a phase 3 multicenter randomized open-label trial, Ruxolitinib was compared to best available therapy in 319 patients who developed steroid refractory grade 2 to grade 4 GVHD, and they demonstrated a significant improvement, almost doubling of partial and complete responses to steroid refractory acute GVHD. The most important treatment-associated side effect was thrombocytopenia, which could be managed with dose reductions and transfusions. The responses were sustained beyond more than 12 months, and addition of ibrutinib improved failure-free survival in this very difficult-to-treat subset. Coming to CME infections, which is a very difficult complication sometimes in stem cell transplant, and CME infection may increase graft failure, graft versus host disease, and propensity to other infections. There are various strategies that have been used to reduce or combat CME infection, which most commonly used strategy being preemptive therapy. Francisco Marti and colleagues tried to look at a new drug called Letermovir for CME, which was shown to have significant activity against CME, and they used this in a prophylaxis-like strategy. They did a phase 3 double-blind randomized control trial in patients who are CME seropositive undergoing stem cell transplant, and they randomized Letermovir versus placebo, the primary endpoint being clinically significant CME infection. They used Letermovir at a dose of 480 milligrams, and it was continued from post-transplant till week 14, and CME was monitored twice weekly. They demonstrated clinically significant, almost half, decreasing the occurrence of CME infection by almost half. And they also demonstrated in an exploratory subset analysis that addition of Letermovir reduced the risk of all-cause mortality in addition to reducing the risk of CME infections. More than half of patients with high-risk AML, in particular FLT3 mutated AML, do relapse post-allotransplant, and it is an area of need to reduce the risk of relapse post-transplant. There have been recent advances in this area where investigators have used FLT3 inhibitors and hypomethylating agents to try and reduce the risk of relapse post-allotransplant. In the SORAMAIN trial, the investigators randomized 83 patients between placebo and sorafenib. This was a phase 2 double-blind placebo-controlled trial done in Europe, where sorafenib was used for 2 years as maintenance in FLT3 mutated AML patients. At a median follow-up of 41.8 months, they demonstrated a significant improvement in relapse-free survival and overall survival in patients who did receive sorafenib post-transplant, with an impressive hazard ratio of 0.39 and 0.51 respectively. We're looking at the toxicity with sorafenib. There was an increase in skin and GI toxicity, and also increased rates of GVHD with sorafenib. However, sorafenib did improve survival significantly, and this makes sorafenib the standard in FLT3 mutated AML patients undergoing stem cell transplant. For quite some time, unrelated matched adult donor was considered as an ideal donor in patients who didn't have a sibling matched donor. However, there are problems with a MUD donor. There is poor access in especially non-Caucasian patients due to lack of adequate donor pool. There is a longer time requirement to identify the ideal donor, and many times the cost can be prohibitive, especially in countries like ours. Haploidentical donor transplant has been around for quite some time now. However, there was concerns whether haploidentical transplant donor meant more toxicity and poor outcomes compared to a MUD donor. To answer this question, CABMTR conducted an analysis of continuous patients between 2008 to 2012 and compared haplo and MUD in acute myeloid leukemia patients. And 104 haploidentical transplants were compared with more than 1,000 MUD transplant patients, the primary endpoint being overall survival. This curve shows the outcomes in patients in terms of non-relapsed mortality in RIC and MAC transplants, and in both, the non-relapsed mortality was more in unrelated donor transplants. And when they looked at the relapse rates, the relapses were more in the haploidentical transplants compared to the unrelated donors transplants. And the trade-off was obvious when they looked at the overall survival. Both in the RIC and the MAC transplants, the overall survival was similar when they looked at the survival because of increase in mortality due to relapse in haplo and increase in mortality due to non-relapsed mortality due to causes like GVHD in MUD transplants. So if you look at the CABMTR registry data over last few years, the number of patients who get haplotransplant has been progressively increasing because transplanters are becoming more and more comfortable with this strategy. This is the Indian Society of BMT data, and the number of haplotransplants that are happening in our country seems to be increasing. However, the MUD transplants remain static. Coming to CAR T cell therapy, the central challenge in immuno-oncology remains that most tumor antigens are self-antigens, and tumor takes advantage of the mechanisms ingrained in the immune system to prevent autoimmunity. And many times, anti-tumor responses are transient and ineffective. CAR T cell is a new strategy that has been used. In other words, it's an autologous cellular immunotherapy where T cells are reprogrammed by gene transfer, and These are able to recognize and eliminate cancer cells by targeting tumor-associated antigens more easily. The figure in the left side shows the conventional way of how the T cells recognize tumor antigens, and this requires the HLA on the tumor or the target cells to present the antigen to the T cell. However, in the chimeric antigen receptor technology, the tumor antigen is recognized irrespective of the HLA, and the T cell is able to destroy the tumor cells more easily. Why CAR T cells are very important and are the future is because the uniform poor outcomes in various relapse settings. These slides show poor responses from the MRC study and the SCHOLAR-1 study respectively for ALL and diffuse large B-cell lymphoma. The ZUMA-1 trial looked at the outcomes of relapsed refractory DLBCL patients who received CAR T cell therapy, and they demonstrated astonishing overall response rates up to 82% and CR rates of 54% with a median duration of response of 8.1 months. And these responses were sustained over a long period of time and were much better compared to historical controls. Similarly, in ALL, we have seen very good remission rates and relapse-free survivals when CAR T cell therapy technology has been used. There are unresolved questions still plaguing CAR T cell therapy. This include how long are these responses? Are these responses durable enough? Can we avoid transplant post-CAR T cell therapy responses, or does all patients having responses after CAR T cell therapy, do they require to undergo transplant? And the mechanism of relapses after CAR T cell therapy are being investigated. And ideal target antigen for CAR T cells are also being investigated both in hematological malignancies and solid tumors. To conclude, Ruxolitinib is a new treatment option for acute GVHD. Ibrutinib is a new standard of care for chronic GVHD in the second line. Letermovir is a new novel drug for CME prophylaxis and should be used if available. Sorafenib reduces the relapse after allostem cell transplant in acute myeloid leukemia. And HAPLO stem cell transplant is as safe and as effective as MUD stem cell transplant. And CAR T cell therapy is the new standard in relapsed ALL and DLBCL. I thank the organizers for giving me this opportunity. Thanks.